everybody. Welcome to our Advanced Risk Summit Thursday night series from AO North America. I'm Marco Rizzo, and I'm the moderator of today's session. Tonight's session will be on wrist arthroplasty. We have a wonderful faculty tonight. Dr. Amit Gupta, who's professor at the orthopedics at the University of Louisville, will be presenting. Dr. Brian Adams, who's professor of orthopedic surgery at Baylor Medicine and vice chair of academic affairs, as well as co-director of the hand surgery fellowship in Houston, Texas, Baylor Medicine. And finally, last but not least, Dr. Lee Osterman from the Philadelphia Hand Center is professor of hand and orthopedic surgery at Thomas Jefferson University in Philadelphia, Pennsylvania. Myself, I'll be moderating. I'm from Mayo Clinic, and this will be an exciting and most educational event. Because our faculty are such expert in these areas, they do have relevant conflicts that were mitigated and vetted out. Both Dr. Adams and Dr. Gupta have been involved in designing implants, and Dr. Osterman's also done extensive consultant work as well. A couple words about Zoom etiquette. All of your microphones have been muted and your videos turned off. There is a Q&A box that you can use in Zoom for discussion topics. Not the chat box, please, if you can. So today's session is on wrist arthroplasty. The subsequent two sessions, which will be April 1st and April 8th, will be arthroscopy next week. And then the following week will be a rounding out of the sessions with all the faculty and take-home pearls related to each of the topics and sessions we've had since January 14th. You can access these recordings on YouTube, AO and North America, 24 hours after the conclusion of this webinar for all those who are registered. Again, our topic today is on wrist arthroplasty. We had a nice discussion 2 weeks ago on wrist arthritis, which was a nice sort of a precursor to this. And we'll talk a bit more about this by way of introduction. Again, I have no relevant conflicts. And as we get started, we do have learning objectives, as you can see through on this slide, understanding the role of wrist arthroplasty, detailing the technical aspects of the procedures, and knowing complications and salvage options associated with failure. I'll bring the clock back maybe almost a decade. There was a paper published by Yi and Touré looking at a meta-analysis of wrist arthroplasty, and over that review, which was about 5 years of literature up to that point, you can see the demographics of the patients and the DASH scores and follow-ups. Basically, what they noticed was a few implants had favorable DASH and motion and survivorship that were better than some of the others, and complication rates as well. But overall, when you compare it to total wrist fusion, these authors had a pretty damning statement about wrist arthroplasty. They basically concluded that the evidence does not support the use of arthroplasty over arthrodesis, and careful patient selection is necessary. Over the last 15 years, though, there's been a real development, and I think a huge progression of advances with wrist replacement. And there are patients who really need and want motion. And I think it's important to have that understanding as you see them. This is a case example of a 61-year-old male who has bilateral wrist arthritis related to crystalline arthropathy. He went on to, and you can see the lateral views on both sides. He went on to have an arthrodesis of his right side, for which he was fairly satisfied with the pain relief, but quite frustrated with his lack of motion. And for him, another fusion on the contralateral side was just a very, very daunting prospect for him, and really created a lot of stress for him. So in this case, he underwent a wrist replacement. And again, while most of us will agree, and the faculty will share their experiences as well, that these patients are very happy when they, at least early on. And again, I'll talk at the end about some of the things and the hiccups that we run into. But this is a very satisfying, pain relieving, and functionally maintaining procedure. And that leads us to another meta-analysis that was about 5 years after that last one that was damning. And they did highlight that with the newer generation implants that there is hope. There's better results with these 4th generation implants, as you can see with the Universal 2, and now there's a Universal or Freedom Wrist, which is Universal 3, the Motec, which isn't available here in the United States, but the Remotion rates of success are quite good. And sadly, the Maestro is no longer on the market, but even that had pretty good survivorship at 8 to 10 years. They did concede that there are higher complication rates with arthroplasty, but that sort of goes without saying. You know, it's a higher risk, but a higher reward endeavor. And that's my introduction to this topic. And I'd like to introduce first Dr. Amit Gupta, a good friend and an expert on wrist arthroplasty, who's going to talk about his indications for total wrist arthroplasty. Amit.
Thanks, Marco. So here, let's start with the screen share. Okay, can you see my screen? That's okay? All right. So thanks, Marco. Thanks for inviting me for this session. I'm going to talk about total wrist arthroplasty. I'll briefly talk about my disclosure. So you heard that I had to give a special disclosure. Learning objectives, rationale for total wrist arthroplasty, understand the design considerations, indications, and analyze results and survival of implants, and a little overview of the literature. So the wrist arthrodesis, partial or complete, is the traditional management of arthritis. We have to look at the quality of results. Management of complex wrist problems, I think, follows evolution of management of other joints like the hip, knee, shoulder, and elbow. And I believe that with the reliable total wrist design, the indications of total wrist arthroplasty will increase. So right now, we are doing this or this with KY fixation, 4-corner fusions, and we get reasonable results, about 40 degrees extension, about 30, 40 degrees of flexion, and so on. But when did we last do these operations? Hip fusion and knee fusion, but we keep doing this procedure. And it's not a slam dunk. In certain, literature, you can see that there's 40% only satisfaction with the wrist fusion at a year. And in Ade's work, 100% patients who had wrist arthrodesis would choose to have another procedure that would move their wrists again. So people are demanding movement of the wrist. And the bar for giving a functional range of motion of the wrist is very low. Palmer's work showed that extension is only 30 degrees, flexion 5 degrees, and radial deviation 10 degrees, ulnar deviation 15 degrees. Question is, can we provide our patients this amount of motion in their wrist safely and consistently in the 21st century? Why don't we do wrist surgery? Because we've been bitten in the past by very complex failures of many of these implants. So how should an ideal wrist replacement look like? Well, it can be one of these because it's huge and it's got a ball and socket design. Or it can be this because it's got a hinge design. So it transmits the forces to the metal bone interface, and it requires massive bone excision. It can be this because, again, it takes out a lot of the bone, and it's got a long lever arm which goes into the metacarpal. So what we want to do is minimum bone resection. We have to plan for salvage because it's not if, it's when this will fail. What are you going to do? We need to preserve the DRUJ if that is preserved. We want to preserve the wrist ligaments. We want to preserve wrist proprioception and respect passive and active stability of the wrist in terms of the wrist ligaments. So the amount of resection that is required in the modern day replacements is very small. So you can see that you can easily fuse these if this were to fail. Like the amount of bone resection required is very little. So you want to provide optimal carpal fixation, optimize the degrees of freedom that are available in a design. Ellipsoidal joint bearing surfaces have been shown to provide better function and avoid cement and provide intrinsic or relative stability. So Jay Menon noticed that, a lot of the times you have rheumatoid wrist and you have intercarpal fusion. So why not create a mass in the carpus, and then you can keep the implants inside the carpus. Then the question of how many degrees of motion do you have? So if you have these degrees, there needs to be enough muscle tendon units to stabilize this. So you need N+1 muscle tendon units to stabilize the number of degrees of freedom. So you can't have a ball and socket joint because that's got multiple degrees of freedom, and therefore we don't have enough muscle tendon units in the wrist to stabilize a ball and socket design. The first universal was a toroid design, but then there was a beautiful a finite element analysis by Brian Adams, who showed that ellipsoidal designs were really the best for total wrist replacement. And this is one of the implants. So in the remotion design, it's a metal coating. It's got minimal bone resection. We remove the cancellous core of the radius and use the cancellous bone for grafting, maintain the rim of the radius, and therefore maintain all the ligaments and maintain the DREJ integrity. So, so you have an undercut surface to avoid impingement of the nerve or the tendons on the volar aspect. And here's the cup. So it's uncemented. And this is a design view showing the screws that will go through these areas and the ultra high density polyethylene insert, which has 10 degrees of motion. And these screws are offset, so you don't want to flatten the carpus. And if you flatten the carpus, you'll put a lot of stress on the transverse ligament and create problems with carpal tunnel. So these have been outlined, and further finite element analysis have shown that the remotion risk actually does bring the joint forces back to the normal situation as compared to the rheumatoid or disease wrist. So the first case that we did was this one, a rheumatoid patient with pancarpal arthritis, and this was done in 2004, and this was the implant put in, and here it is. The second case was this gentleman who had a failed four-corner fusion. He was absolutely adamant that he did not want fusion. So what I do is I take these two layers of the retinaculum. One is going to go below the or volar to the surface of the extensors. One will be the retinaculum proper. So one will act as an extension of the dorsal capsule. So this is the implants put in, and this patient has gone from, he still has his implants, and he's doing very well. He's had a little subsidence, but overall he's doing very well. Indications are inflammatory arthritis, mostly, but obviously with the new medications, we don't get that many inflammatory arthritis anymore. So our indications have been expanded to include degenerative arthritis, post-traumatic arthritis, and complications of surgery for arthritis. And here's a study which showed that in 2003, 2004, the indications were mostly inflammatory arthritis, and the pink bars are the non-inflammatory arthritis. And subsequently, it seems that the non-inflammatory arthritis indications have increased tremendously. So rheumatoid arthritis, you can have pancarpal arthritis with ulnar subluxation, distal radial joint arthritis, and we did the, and sometimes, in these situations, you can use a little amount of cement, which tends to stabilize the joints and softer bone. And we replace the ulnar head also in this patient. And on the other side, the same thing. So here's the patient. She's undergone one revision of one side in about 15 years, and she's done very well. Another patient with pancarpal arthritis and DREJ arthritis who had the wrist done, and she's done very well. Similar patient with the rheumatoid arthritis with total wrist as well as U-head replacement, and here's his range of motion. And he's gone about 10 years with this with this total wrist. The 73-year-old patient, 7-year history of wrist pain, multiple injections, range of motion extension 40 degrees, flexion 20. Patient does not want wrist fusion. So there's ulnar deviation or ulnar translocation of the corpus, DREG arthritis, and we did a total wrist. And the contraindications for RA is if there is no bone or very minimal bone or diminished bone stock, very osteoporotic bone, and that would be a relative contraindication. Soft tissue imbalance. If you don't have tendons which will extend your wrist, then probably it's not a good idea to go for wrist arthroplasty. Wrist fusion would be probably a better option. And younger age group, a relatively younger age group, but sometimes you can, with GRAs, we've done total wrist in those instances. And here's a patient who has quite significant bone loss, and you could argue that you could do a total wrist, but there's a lot of collapse of the corpus, and you have to modify your methods. This patient is a 42-year-old patient who has rheumatoid arthritis. Patient is in Humira, and both sides are involved. So on the right side, this is the situation, and here on the left side, patient has arthritis with ulnar translocation of the corpus. The question is, do you go for total wrist or do you go for fusion? Patient wants stability, she wants strength, and we went for fusion on one side and arthroplasty on the other side. This patient has degenerative arthritis and had fusion about 16 years ago, and this was her range of motion on the left side, and this is her range of motion at the present time. And she's done well. She's got a little bit of, she's developing a little bit of scalloping here, a little bit of cysts, and I'll come back to this and we'll hear a lot more about this. And these are somewhat worrisome in certain instances, but the implant is well fixed. This patient had wrist arthroplasty, and she's done exceedingly well with excellent range of motion and has been very happy for about 10 years now. Patient had attempted fusion and did not like it, so we opted to do a total wrist arthroplasty in this patient, and here's a total wrist. So the problems are sometimes when you do it for complex problems, it's difficult in finding anatomical landmarks. There'll be tight spaces, there'll be contractures, DREG problems, nerve problems. There can be tendon problems. So you have to make a wide exposure and liberal use of intraoperative imaging, and we have to create space for the implant. I stretch the space by using laminar spreaders. I excise bone off the volar capsule, and we may require carpal tunnel release and careful hemostasis. This patient had collapse after a proximal row carpectomy, and as you can see, it's trying to sublux, the wrist is trying to sublux volarly. So now you have to create space. So stretch that space out, take out all the bone from the volar capsule, and I take out the pisiform and put it as a substitute for the scaphoid, because the distal pole of the scaphoid is missing here. And liberal use of bone graft, and the capsule has to be extended with part of the retinaculum. And this patient has done well with and been very happy with the results of a total wrist arthroplasty. This patient had a malunion of her radius with intra-articular fracture, which she had developed arthritis, and this requires a certain modification of the procedure. However, we were able to achieve that, and she has been happy. Now, can you convert a total wrist arthrodesis into arthroplasty? Well, you can, technically you can, but it will result in a very expensive arthroplasty because the movement that you'll get is not much, and we certainly would not recommend doing this procedure or converting it. Patients have failed four-corner fusions, can be converted to total wrist arthroplasty. This patient is a 73-year-old person, has bilateral wrist pain, right total wrist replacement, left wrist proximal row carpectomy in 2018. Patient has pain and deformity in the left wrist. So at right total wrist and left side, the proximal row carpectomy, which then collapsed and subluxated. So here, the problem is that total wrist is not going to be a beneficial thing, and therefore we opted to fuse this wrist. And the patient had one side mobile wrist and the other side was fused. This patient, 63-year-old psychologist, bilateral wrist pain for years. In October 2018, had left radioscapholunate arthrodesis, done elsewhere. And on November 2018, the same surgeon did right proximal Coppectomy. Both surgeries done elsewhere. Patient had continued with pain. In June 2020, I saw the patient and patient underwent, patient had a motion like this. Extension was 20 degrees, flexion 30 degrees, and left wrist was 30-30 and quite painful. So here's the right wrist with PRC, which has failed, and left wrist with the attempted proximal fusion, which has failed. So he wanted motion, so right side arthroplasty and left side went arthroplasty with direct. And this is his current range of motion, 50 degrees, full pronation, supination, left wrist 50 and 60. So I think we can stop at this point because I'll go ahead and give it back to Marco, and we'll take any questions that you may have. So I'll stop sharing my screen. Thanks, Marco.
Thank you, Ahmed. That's outstanding. A lot of wisdom there. I did want to let the attendees know. Please feel free to chime in questions in the Q&A box. That'd be great. We'll man them throughout the session. Ahmed, one thing I noticed on one of your photos, just real quick, you talked about using the pisiform. How do you determine when to use the pisiform, when not to, when you're trying to salvage like someone who's had a previous scaphoidectomy? Do you do it every time, or do you just do it sometimes?
I have started doing it most of the times because, number one, I don't want the pisiform to act as a structure which will cause pain, and sometimes it does on the ulnar side. And then it gives me bone graft to fit in where the screws go in through the radial side. Okay. Otherwise, the screws are don't have enough punches.
Gotcha. Thanks again. I'll go back to my screen, and then
Marco.
Oh yes, Chuck.
Hey,
how are you, bud? Good, bud.
I'm doing well, thank you. Amit, terrific presentation. Just a question. You've done these wrist replacements in a variety of situations and scenarios. What are your restrictions in terms of lifting and activity after wrist replacement?
You know, we don't have the functional, restrictions, any studies which show the functional restrictions. So I tell my patients 10 pounds, but nobody listens. Once their wrist becomes painless and they got mobility, they just keep doing stuff. And then, most people come and say, oh, I've been lifting, I've been playing golf, I've been doing this and that. So nobody will listen to you. So I've pretty much given up giving instructions on restrictions.
One thing I add that I do think they follow, at least the more diligent ones, is to, this is Brian Adams, is to have them wear a wrist brace when they're doing more strenuous activities. And I do think they'll do that. And then I tell them to avoid really the push-up type activity. So pushing out of a chair or pushing a door open. They usually get used to just pushing their wrist more in the axial loading. And then lastly, I really ask them not to do impact loading, like using a hammer. I think those three are the most important that you can really help the patient for potential increase their durability.
That's a good question. That brings up a good question, Brian and Amit, and certainly Lee, chime in. What if you had to do something at the ulna? If you had to do a DARA, would that change how you advise a patient with regard to activity versus I seen Amit, you had done a couple U heads or quite a few U heads with or just left the DRUJB. Does that change how you advise patients?
If the DRUJ is stable and it's intact, then I think that makes for a better situation. In rheumatoid patients, if I've done a DARA, then obviously in many of these patients, they have very low use of the hand anyway. So they're not lifting stuff and carrying them around. So I don't restrict them in that sense, but I try to preserve the DREJ if at all possible, as much as possible. If the DREJ, especially in the degenerative or post-traumatic situations, if the DREJ is intact, I try to preserve it. I would not go towards the ulnar side at all.
Ryan, Lee, thoughts on those?
I would just,
Oh, go ahead.
this is Lee. I would agree with what both Amit and Brian said. Once these people have pain-free wrists, I don't care whether you've done the distal radial ulnar joint or not, they want to use their wrist to tolerance. And so I think we only are trying to cover ourselves when we say don't lift more than 10 pounds, et cetera. And I pretty much do what Brian does, tell them to use a wrist brace and say, listen, this is a machine. And just like the tires in your car wear out, the harder you use them, the more likely you're going to have a flat, the more likely you're going to have some replacement. And each time we have to do that, it isn't back to square one, it's back to square two. And most patients, I think, get it. They certainly get it on the revision. They may not get it the first time around.
Thanks, Lee. Brian?
Oh, no, I was just going to say, I work very hard now to preserve the DRUJ. Obviously, none of us are seeing the number of rheumatoids anymore, but it does allow us, I think, in the non-rheumatoid to think twice about preserving, even if it's a hemiarthroplasty, or as I'll be talking in a minute, or a dome resection. I think most of the time you can do something to preserve it. Even if it's mildly subluxed, I'll still try to keep it intact because I think it helps a lot with the stability of the wrist and maybe the durability too.
I think I'm a bit of a black sheep. I don't know. I think a lot of the community hand surgeons, at least here in the upper Midwest, don't do rheumatoid anymore. And I've just been keeping a steady flow of rheumatoids. Speaking of which, this is just a couple questions on to the panel about this case. This 39-year-old male, he was 37 when I first met him. And he has he had these x-rays and I consider this patient. I noticed to me you had a 40-year-old and some younger folks that you do this on. So I think I'm going to know the answer to your question as we move forward, and especially since this is a discussion on arthroplasty, sort of spoiler alert kind of thing. But I ended up fusing his dominant right side 2 years ago, and this is his x-ray. And he's quite happy with his pain relief, but quite frustrated with his lack of motion. And his left side is quite symptomatic. I tried to convince myself that maybe a radioscapal lunate fusion would be doable, but I really didn't think that was even an option when I looked closer at him, and I don't think that would have worked anyway. And am I crazy to consider an arthroplasty in this patient?
No, I think patients don't do well with bilateral fusions, and this patient has good quality, has good bone stock in the carpus. As ulnar subluxation, you can correct that. You can centralize the wrist, and I think you'll be okay with the wrist arthroplasty. You'll give him good 10, 12 years with wrist arthroplasty, I think.
Okay, thanks, Amit.
And I think quality of life is improved. In the JRA, they usually have multiple major joint involvement of the upper limb. A lot of times their elbows stiff, their shoulders can be stiff. You're not showing the full fingers, but they'll eventually get stiff. So any motion helps them for their quality of life. And I think now we have a fairly good solution, and I think you're going to talk about it later, about conversion from a failed wrist, if that's what you choose, to a wrist fusion. So I don't think it's a disaster to offer it to these patients, but I think we have to be honest with them. Again, they're young, and just like everything else in our body, it's going to wear out, and they're just going to wear out a little bit faster at the wrist if you do an arthroplasty. But I wouldn't hold it against them and say they're contraindicated, but I would certainly lay it out there what the expectations are.
Thanks, Brian.
Marco, one thing that I would say, aside from agreeing with the remarks that have already been made, is sometimes these JRAs have very poor motion to start with in their wrists. And sometimes when you do a total wrist replacement, they don't get the motion that we see on a standard basis. You'll see more of a contracture. And that always concerns me a little bit, but certainly it's better than bilateral broomsticks for arms.
Thanks, guys. Appreciate it. So that leads us to, we'll come back to him in a bit. I'll circle back, but Brian, Dr. Adams will talk on the surgical techniques for optimizing wrist arthroplasty. I'll stop sharing here, Brian, okay? And thanks for sharing your wisdom and experience.
All right. Can you hear me, Marco? All right. Well, there'll be some overlap with what Amit talked about, and I apologize for that, but I don't think it'll hurt. My task really was to, we've already highlighted the patient selection as I think is a key factor for durability and longevity, but execution is also really important. And then obviously we've talked a little bit about already about limitations to increase your durability. But we can't, I think, bypass that there's a lot of details in the execution that probably impact the durability and the overall function of the implant. And I'd like to just go through some of those highlights. So I'm going to be covering these 6 things. Let me just state what they are, and that's preserve the capsule, bone, and DRUJ as best you can. We've just talked about the DRUJ. Be ready to modify the joint and the bone if there's any deformities, but typically we don't have to do a lot of modification in our technique. Manage the soft tissue contractures. We just talked about that. Don't expect you're going to be able to use rehab later on to create a more loose wrist. You want to have the motion that you're setting out to obtain intraoperatively. Select the proper size components because we don't want to overstuff the joint to make it too tight, but we don't want to put in too small of an implant that would potentially impact stability. Obtain proper implant fixation, and I'll talk about this a bit more. But again, what your long-term is that you have good osseointegration. And then finally, a precise closure to avoid secondary contractures, to be able to optimize your range of motion. And I believe in a watertight closure as best you can in order to reduce postoperative swelling. So let me cover all of those things in a bit more detail. I still prefer a distally based rectangular exposure. I preserve the entire DRUJ and the ulnar side of the wrist so that the ECU is preserved, the TFC is preserved. You modify that slightly, but through a different incision if it's a rheumatoid. So I don't expose the DRUJ at the same time that I expose the carpus like I did 20 years ago. I think the flap can be raised to the level of the capitate head, capitate neck and through the proximal pole of the hamate. That's a good guideline for where that flap needs to be raised in order to flex the wrist fully as well as the proper exposure. The capsulotomy, the osteotomy through the carpus should be as precise as you can so you're not taking off too much bone. That's where our Achilles heel is most of the time for wrist replacement is distal fixation. So you want to preserve that bone the best you can. And typically it's through the proximal pole of the hamate in most systems that are out there. I think the triquetrum can be sacrificed. The main reason not to sacrifice, in my opinion, is that it does help hold the pisiform down, which can drift up. I really haven't seen that as a problem. So I've been more liberal about taking out the triquetrum if it's only a fleck at the time. On the radial side, I think we want to protect the DRUJ and protect the radial ulnar ligaments the best we can to preserve that DRUJ stability. So the resection can be into the radius, but again, avoiding that more ulnar side of the radial aspect of the lunate fossa. And you're seeing here how that is really preserved in this particular case where the implant essentially left the DRUJ completely alone. In order to do that, we're going to only resect the dorsal rim of the radius and leaving the volar rim of the lunate fossa completely intact to preserve that capsule, unless there's volar subluxation in which that needs to be resected to avoid impingement. And we can talk about that a bit more. So in this case, you can see the entire lunate volar portion of its facet was maintained. The capsule is still attached there, and therefore it adds to the preserving stability for the wrist, which then allows you to perform immediate motion on these patients. And that's what I prefer. At least by 10 days, I'm moving them through a nice active wrist extension arc. I avoid flexion in order to keep stress off the dorsal capsule. In general, we want to try to preserve or restore the axis of motion of the wrist, which we know in a generalized sense is through the head of the capitate, both for volar dorsal as well as radial ulnar. As Dick Berger did that study, this is right out of that with Adrian Flatt at Iowa and the first biomechanics lab in the United States on the wrist. So I think it's held the test of time that if we try to reproduce that, we're more likely to restore motion and provide stability and maybe durability also. We have to manage the soft tissue contractures, however, that may be present, both the capsule and the tendons, so that you really can put this wrist back where it belongs. And I'll kind of cover some of those. So in this case here, you see there's some actually radial translation of the wrist as it's collapsed. And we want to try to restore that longitudinal axis of the capitate head lined up with the lunate fossa. Implant sizing, I think sometimes we underrate. And I think it's very important because it really affects stability. Again, as I mentioned, if it's too big of an implant, it might affect tightness, overstuffing and motion. If it's too little, then you won't have enough capture and you might have an unstable joint. It also has an impact on fixation because you want to line up, depending on the implant system, where the stem and the screws are going to go. And then oversizing can affect the DRUJ. So in this case, you see the capitate or stem is centered in the capitate. The ulnar screw is down the long axis of the hamate, and the radial screw goes down the axis and aligns with the second metacarpal. And on the radial component, you see it preserves, again, the DRUJ and the TFCC. And again, if you put in too big of an implant, you'd probably affect those things. So implant fixation, believe it or not, the FDA is only, in the United States, has only approved cemented ones, but they sort of ignore the fact that most of us are putting these in uncemented. But what we want is a nice press fit proximally. We have good bone indications. Metaphyseal bone tends to on-grow under our implants well. We can have press fit distally of the central stem and then screws as introduced by Jay Menon and the radial and ulnar side. But don't forget, cement can really be helpful. Some of my most durable patients have been cemented. So if you have poor bone or cystic disease that you need to make up for, don't be afraid of cement. And then as Alberto Uke introduced, and later on Jay Menon emphasized, is we want to do an intercarpal fusion because our goal is to convert a multi-articulated joint into a two-bone joint. And I can tell you some of my best results have been those that have already had auto fusion in the carpus, because then it's really simplified for you. So here you can see the intercarpal fusion using Watson's concept, where you don't want to break up the entire architecture, was performed in the intercarpal spaces and get a nice fusion. You can see this is just intuitively obvious that this is going to support the capsule much better. I'm sorry, the implant much better. For closure, really, you want to try to get a watertight closure, and but you also want to avoid shortening, because I think this is where we often lose the ability to get flexion in these patients. You're in a rush to get closed, you want a nice closed capsule, but augment it if you need to be. You can use the retinaculum as an interposition, half of it, like many of us done for years with the rheumatoid. And also, I think I like to transpose the ECRL and ECRB and EPL into a subcutaneous position, so you don't pinch the tendons, and if you will, and allows a looser retinaculum. And don't be afraid to use allograft during your closure. So if anybody's more complicated, I like to use tensor fascia lata allograft. I think it works beautifully. I've used it for years. You can use it for the dorsal capsule, most common. You can even then reflect it to make a retinaculum if you like. And then I've even done it, much less common, but you can actually create the volar capsule, bring it around after you put the implant in to create a dorsal capsule, and then again reflect it dorsally to create a retinaculum. So it's a really versatile allograft that you can use. So in a case like this, I'll always have it available because I don't know what I'm going to have at the end of that case for closure. And if I make it too tight just to get coverage, well, then I've lost a lot of the reason to do an arthroplasty in the beginning. So I like to have checklists, being an aviator, a mandatory actually use of them sometimes. But I think they're really a workhorse for complex cases. And so this is a checklist. I'm going to go through cases to kind of highlight it. You want to look for carpal malalignment. If you have wrist height loss, either on the carpus, the radius side, or both, whether there's any subluxation, volar or dorsal, ulnar translation of the carpus, ulnar variance. Is it positive ulnar variance? It's going to get in the way for your resections. DRUJ condition, as we talked about a little bit. Do we need to address that? It may show arthritis, but they may not be symptomatic there. Bone quality, what is your fixation likely? And then contractures is often underrated. So if you want the perfect patient, here it is. 72-year-old older, right hand dominant, right wrist has already been fused, left wrist looks terrible, as you can see. He doesn't want bilateral fusions. He's low demand, no walking aids, no DMARDs or steroids. This is almost written perfectly, right? But what's our checklist show? Well, we have carpal malalignment that's fairly advanced. We have loss of wrist height, moderate to severe, I call it. And those are our main factors we have to worry about. I think his bone quality is pretty good, and he's ulnar neutral variance. So here, what we really want to emphasize is don't resect more carpus. Take off a little bit more radius, and you can still preserve the DRUJ in more cases. And a lot of times it doesn't take much more to really loosen up the wrist. So there's the key to make this, I think, work. And the implant itself will, if you do those things, will centralize the wrist for you. Here's a very, very similar case, but here we have mild ulnar positive variance. Again, carpal malalignment is advanced. Wrist height loss is also advanced. So similar ideas, only as we shorten on the radius side, we're going to have to do something about the DRUJ. I think I was a little overzealous here, but I typically like to do a dome resection if there's enough remaining ulnar head so I can keep the DRUJ. And my second choice would be to do a hemi-resection similar to the Bowers technique. Another case is now we have a guy not really pretty good here overall. He's a calligrapher, so he really wants to maintain wrist motion, and he gradually got stiffer and stiffer due to his pseudo gout, as you can see here. So overall, from all those checklists, we're really not up against a difficult one, but here we are up against contractures with loss of motion. So when we leave the OR, we got to make sure that we've shortened him enough to loosen this joint up, and that we haven't tightened the capsule so we lose everything that we've really tried to gain. And that's why I like a transverse capsulotomy. I know it's becoming more and more popular, especially in Europe, to do a longitudinal capsulotomy for these. But then when you close it, you really have no method to really lengthen the capsule. So I think you burn some bridges with that. So here you see it's at 5 years out, nice intercarpal fusion, nicely aligned wrist. So here's another case. Amit showed one similar to this. It's a little different technique. I've seen several of these now. Radius malalignment, a previous radius malunion. The rest of you can go through the checklist. There's not a lot to worry about here except for ulnar variance being positive, but his DRUJ arthritis is really not bothering very much, but his contracture is moderate. So we have to worry about motion, and we have to worry about how to manage that radius. Well, one technique I've used is to actually consider using the opposite sided implant. So in this case, it's a right wrist, but I used a left implant and put it upside down, and therefore I did not have to do a radius osteotomy or any really wild maneuvers in order to get this wrist realigned. Several others cases to go through real quickly is, as I'm seeing this more and more often, is failed four-bone fusions and PRCs and other things. And just to make a few comments, one of the biggest problems I think of the failed four-bone fusions, not showing here, but that they had retained hardware, whether it be a circular plate or screws or whatever. And if you take those out, you often destroy a lot of the bones. So you have to be very careful in your planning. Can you get all that out and still get good distal fixation? In this case, it was more of a no-brainer. But the nice thing here, as I mentioned before, he already had his intercarpal fusion. So it was really nice to get good durable result on that patient. Here you can see a lot of preoperative planning goes into this one. You can't use your wrist guides anymore for the implant because you got a radial ulnar fusion. You're gonna have to cut through that first. I took out the ulnar silicon implant. There's contractures here, there's shortening. But in this case, we can shorten the wrist a bit more on the radial side in order to get it done. And I think so you can even take some of these difficult cases and make them work. I have a little bit of difference of opinion in Amit. I think you can convert some total wrist fusions to total wrist arthroplasty. The only ones I've done, however, are those where they have bilateral complete wrist fusions and they just don't like it. You do need to, a lot of planning here to know where your osteotomy is going to be through the carpus and the radius. Most of the time you have to lengthen the ECRL and or the ECRB and perhaps the ECRL. And you really need to augment the capsule in order to get reasonable motion. So I would consider it. The biggest challenge I see and I get questions the most about is the failed PRCs. And here we have to, again, go through our checklist. The main concern here is wrist height loss. It's usually pretty severe. Some of them have significant ulnar translation. They've sort of fallen off the radius. Obviously there's bone loss where the scaphoid was if it was a full PRC, and then most of these at least have some mild contractures. So believe it or not, you still want to avoid that excess carpus resection because then you're going to lose implant fixation. So you have to create the space on the radial side. And one of the ways to do this is to cheat a little bit and tilt your radial component into a more flat position to sort of avoid that concept that the typical scenario where we try to match more of the natural inclination, and you have to sink it. And if you deal with that correctly, unlike using the pisiform, I haven't used that, you can actually use the bone out of the radius if you plan ahead, and that can help fill that gap for the scaphoid. So that's my preference. Last two things is, when is it too much osteopenia to do this operation? I don't know the answer to that. I like to check them for vitamin D deficiency and check their osteoporosis out for sure and maximize that. I just did it the other day and she was on these drugs for 6 months and then we did the total wrist. But here's a case 5 years out with very little migration of the implants, a little bit distally, and holding up beautiful despite that osteopenia. So maybe this one is just a low demand patient, I'm not sure. But I wouldn't say don't do it, but definitely maximize their bone. And then the last thing to conclude with is an article that Christina Ward and I wrote together a long time ago, looking at the radiographic, primarily the radiographic failure rate in severe rheumatoids on all kinds of medicines. And it was a high failure rate. Most of the patients, however, were happy with it. So we declared that it was about a 50% failure rate, again, radiographically, not clinically, and not necessarily the full revision. So I try to avoid these patients when they look like this nowadays, even if they're bilateral and they look like this, which fortunately we don't see as often. So with that, I'll conclude. Thanks for listening to me and good luck on your next procedure.
Thanks, Brian. That's outstanding. Tremendous wealth of experience. I really appreciate it. Brian, while we have you here, I'm going to go back to our patient. I'm just going to share my screen real quick if I can. And
there, I stopped share. There we go.
Great, buddy. Thanks. And I will ask, there's so many pearls, so many things we could talk about. But just to highlight a few things, let's go back to our patient who I ultimately did move forward with a wrist replacement intraoperatively. Brian, and certainly Amit and Lee, feel free to comment as well. I'm doing a remotion here, Brian, and when you look at that capitate longitudinally on the side view there, what are your thoughts? Am I too distal? Am I too dorsal for my peg placement there? Or is my cut off?
Yeah, I think the JRA can have a lot of remodeling of the carpus, and it is a major challenge. A couple things, though, as you brought up that are really important. In the adult RA, they tend to be ulnar deviated at the CMC joints, even the third, although it's not supposed to be mobile. And it can be the exact opposite in a JRA, or in this case, you're seeing that it's more longitudinal. But most of these JRAs will have a humpback at the CMCs, which is a bit of a challenge. So I think you're probably okay, but I would tend to try to line it up generally as best I can with the metacarpal, rather than put it in necessarily straight away with the longitudinal axis of the capitate. And the
Okay.
reason for that is that I think when you then go on to put your screws in and other things, if they've had an auto fusion across the CMCs, that allows you then, and I've done that several times, allows you to put the screws then straight into the bases of the metacarpals. And if you put it too dorsal angulated, then you can't get them into those.
Thanks, Brian.
Marco,
I mean,
Marco,
this is your implant, so.
In this case, I would try very hard to go slightly volar on the point of entry and aim more centrally towards the capitate. And I try very hard to get a osteotomy at 90 degrees to the long axis of the third metacarpal.
Okay. So I did reposition it a little bit more volar. Lee, any thoughts? What are your thoughts here? I mean,
well, not much to add on the bone alignment, but some of these patients, Brian alluded to it about the wrist extensor issues, and he talked about lengthening the wrist extensor, which sometimes I think you may have to consider in a JRA to get that motion that you're trying to get. A number of questions have come up in the chat room, though, for Brian about, has he gone away with the fact if you don't have very effective extensors, would you still consider a total wrist, or is that no longer a relative contraindication?
Sorry, I missed the chat, but I'm glad you brought those up. I'd like to also, Lee, you bring up a great point. In my initial series of the RA, which also include JRA, I lengthened the FCU in more than 50% of those patients, because that will really reduce your ability to get extension. So I have a very low threshold for rebalancing the wrist flexors and wrist extensors, because I think that's as you mentioned at the outset, that's the best way to get motion. And then don't forget, as I mentioned multiple times, you really need to be ready to do something about the capsule. Regarding the wrist extensors, one little trick that you can, I think ECRB is vitally important. However, I have gotten by with a few cases where it's not great, and that you can bring the ECRL, even in a lengthened fashion, more centralized and actually suture it to the stump of the, or side to side with the ECRB. So I'll have a low threshold for bringing the ECRL over the top to help it become more of a central wrist extensor. And it's actually really easy to do. Yes, you do need some wrist extensor. If they have none from a previous operation, I don't think it's probably going to be worthwhile, because they probably won't. They'll probably drift into flexion severe.
That seems to be the general view of the questions that came, that they felt it was important. My only second point, I agree with preserving the distal radial ulnar joint, but in cases where I've had to shorten the radius to the point that it was going to be a problem for me, I've been very unhappy with doing hemiarthroplasties or shaving down the ulna. And what we've actually done is ulnar shortening in the face of that, which still leaves the dome intact, but changes the mechanics of that joint. And we'll shorten it 2 to 3 millimeters on a shortening. And that's been fairly effective for addressing the DRUJ problems if they're mild in wrist arthroplasty.
Yeah, I agree, Lee, and especially if you want to do it distally rather than a shaft. The other thing is, if you are going to eventually need to do a wide resection, my other caveat, do it early. It will help you so much in the operating room. So I still, as I mentioned before, would do the capsulotomy for the DRUJ separate from the radiocarpal joint, so that you have a nice preservation of a sleeve, if you will. You can close at the end. But by removing the ulnar head early in whatever you're going to do, you sort of free up the wrist and make the rest of your procedure a little easier and easier to balance the wrist.
These are wonderful pearls. Thanks, guys. Hill had brought up a question about how do you know if someone's, to what degree of subluxation can can you, we'll talk maybe a little bit about this if we have time, but how much subluxation or deformity is a point where you say, gee, that's just not a good candidate for a wrist replacement?
Well, as long as the patient has good bone stock and good soft tissue balance, I think you can get by, you can balance the wrist. And I think these implants will balance the wrist as long as you've got radius to third metacarpal, axis to axis alignment.
Okay, perfect. So I'll just take us through this this case real quick, just to show what I did. This is the placement of the carpal component. And I think I corrected the alignment some. I did go a little bit more volar. And this is after the radial component placement. And this is our patient at 3 months post-op. He's coming back in a couple months for his next visit, but any thoughts or comments?
No, I think it's very good.
Okay, looks
Good
like
job.
his the carpal fusion that's been talked about a couple times already. That is key in my opinion. If you have those patients really help that stability, that distal component, which is the Achilles heel, and that leads us into Lee's talk, because you know, as we've alluded to already, there's a lot of concerns with patients in total wrist when the Achilles heel is the distal component for these patients. And Lee's going to share his experience, which is arguably the most in the world, I bet, on hemiarthroplasty and the role of hemiarthroplasty, since he shared his experience from the Philadelphia Hand Center. Lee, thanks for sharing.
I'll share my screen here. Well, can you hear me all right?
We got you. Okay, I
good.
can hear you.
Okay.
Thanks, Lee.
So really my topic is, in a sense, when is half a loaf better than none? My conflicts are listed there. None are particularly related to this talk per se. Whoops, not advancing here. When we think about total wrist replacement, I always think of this song, The Little Old Lady from Pasadena, because for me, total wrist is going to be in someone who's over 65, low demand, has an inflammatory arthritis. When we start talking about wrist loading and activities, particularly of these people in their mid-50s who have slack and snack wrists and are symptomatic, and they say, I want to play golf, I want to get enough activity to play instruments, I want to run my home ec projects with drills, I want to play sports, you have to worry about the longevity of the total wrist, particularly the distal components. And despite the success of joints in the hip, the knee, and even the shoulder, we still have problems with loosening and instability, distal component failure, difficulties of conversion to arthrodesis, and all of these have combined, I think, to dampen our enthusiasm about wrist replacement. The problems with our other standard motion preserving procedures are they need some part of the articular surface to be intact, either the capitate, the lunate fossa, to make those there. And when those are not there, you have difficulty doing that. And so the concept was, for the active wrist, could a hemiarthroplasty, just replacing the radial side or just replacing the carpal side, be effective? Would it give less prosthetic stress? You have limited bone resection, as all the fourth generation total wrist prostheses are trying to achieve. And the concept would be an easier conversion when it didn't take. And so we started with actually one of Boyer and Adams' cases with a hemiradial replacement in several patients who reported some reasonable results. And that led to the concept of the distal resurfacing arthroplasty with or without a PRC, using essentially one half of your favorite total wrist for that. Culp reported in our series looking at using a titanium poly thing with an average age of 64 in non-rheumatoid patients. However, we had a 20% revision rate and 50% other complications. Many of those complications seem related to polywear early on, and then we switched to the metal component of the implant without much change. And so this was the concept at the distal side, say leaving the radius alone, but putting and resurfacing just the carpus, again, using existing wrist components. Again, disappointing results as reported by Brent Bamberger and his group in 2017. We looked at our complications following partial and total wrist arthroplasty in a take all comers. And this was really done about 205 to 212. We had 105 total cases, and you can see about half were total wrist and half were some type of hemi replacement. And I can tell you that while I don't claim to be the best surgeon in the world, I'm certainly not the worst, nor is Randy Culp, the two of us doing most of these surgeries. And we had in this series a 50% complication rate. Some were obvious technical failures, but others were wear failures. At least 39% required run revision. Despite that, I will say, as I think Amit alluded to earlier, most patients were very happy that you were trying to preserve motion. And if you look at the typical Kaplan-Meier survival plot, you will see that the hemiarthroplasties did not do as well as the total implants overall. And so in summary of that consecutive series taking on the non-rheumatoid wrist, we had a 50% complication rate. It didn't seem to matter whether it was a total wrist or a hemi replacement. And while the transition to metal components did have less poly implant type failure, the complication rate was significantly changed. That has led some people to try to do a specifically designed hemi radius. And this is just one example, the Kinetech prosthesis, really popularized by Spacey, Wilf, and others. And the design benefits are that it's a more anatomical design, that it preserves mid-carpal joint motion, and that it maintains the center of rotation somewhat, and it's ligament sparing. Now, that's good if the wrist isn't too deformed. As Brian, I think, pointed out, when you go through your checklist of deformity, there are often wrists that won't meet most of the criteria. They published in 2017 their outcome results comparing 20 patients. Again, the median age is about 50, which is where you see it, dominant hand involved in most, and showed that they increased the flexion extension arc in their patients. They had some increase in radial ulnar deviation arcs, grip strength improved, the Mayo risk score, the DASH scores improved, and most people, 80% or so, were back to their work and activities. And so their early results are encouraging. They did say that if there was significant deformity, particularly in an inflammatory arthritis, that this might not be the choice, and that the modular prosthesis opened the possibility that sometime down the road, you could convert it to a total wrist arthroplasty. One problem for us is it's not yet available in the US of A. We also worry about the effect of loaded metal radioprosthesis on capitate cartilage. There are very few joints in the body where metal on cartilage has stood the test of time. What about a hemicarpal replacement? And this leads us to capitate resurfacing. Well, certainly, often you plan to do a PRC and you get in there and you see the capitate has a lot of wear or is shot, and you begin to question, should I do something else rather than a PRC? Certainly people have suggested capsular interposition, which is popularized by Eaton and showed reasonable results in a follow-up study by Kwan. Joe and Brigley talked about using capitate sort of osteochondral grafts from the lunate to fill in small defects in the capitate, and then interposition using meniscus or using basically other types of wear products have been suggested. Finally, people began to report a resurfacing of the capitate essentially using a prosthesis which was either pyrocarbon or cobalt chrome, and which was better tailored to fit the lunate fossa as opposed to the natural capitate. This was the advantage, that there was minimal resection except for the PRC, and you had a better congruent articulation relative to the fossa. This was reported on, particularly in the European studies, with good results, consistent pain relief, and comparing those who had a standard PRC versus those where the capitate was felt to be not amenable to that until resurfacing. They found essentially no difference between a standard PRC and one with capitate resurfacing, and the fact that the capitate resurfacing was done in a higher grade of arthritis suggested it had a role to play. People began also to look at the role of the cobalt chrome in this and expand the indications for PRC. And so here, this is a study that we did, 32 patients, 33 wrists, again, a little older population, all of them osteoarthritic as opposed to rheumatoid. In a short follow-up, the same outcomes as seen in the Italian studies were there. We maintained about 72% of the contralateral arc. Grip strength was improved. Pain was absolutely improved. Dash scores were improved. Complications were stiffness. One patient with subluxation, one patient with early erosion of the lunate fossa requiring revision. But so far, as this study has gone on, there have been very few revisions. A typical patient is one of mine, is this gentleman who had a distal radial fracture 15 years ago. He had an X-fix and then an ulnar shortening osteotomy. He was a potter and hand painter and threw his own pot, so he wanted some wrist motion. Here we see the wrist that we were presented with. This choice was to do a proximal row carpectomy and resurfacing. And here we see him basically down the road with not full motion. He's had bilateral wrists, one with prosthesis, capitate reshortening, and one without. His grip improved. His motion was maintained. His quick dash has been maintained, and he's back to being a potter. And I've followed him for almost 12 years overall. So in 2021, what do? I still do total wrist arthroplasty in the appropriate patient. I still do standard PRCs and limited fusions. I still do capitate resurfacing prostheses. I don't do any radial hemiarthroplasties. And I think when we think about this problem, when you treat the arthritic wrist, you have to realize the different pathologies involved. I think you have to be versatile and have multiple procedures in your toolbox. I think you have to match the procedure to the patient's demands. And then I think you really have to honestly evaluate your outcomes. And they're not always what the x-ray looks like. It's what the patient satisfaction rate is and how they're able to function. Finally, in the future, which we don't talk about enough, I think we need ways to prevent the arthritis, to restore articular cartilage, and to have less invasive techniques that may play a role in this. And resurfacing and hemiarthroplasty may fit that bill. Thank you all very much.
Thank you, Lee. That's outstanding. Greatly appreciate it. I'm going to share my screen real quick and circle back with you on this. One thing I thought was interesting was how you, can you see that okay?
I can't yet. I see
okay.
you.
All right. How about now? Is that good?
Now I can see you.
So this is a case, I saw that you put the pyrocarbon hemi resurfacing in a different configuration, and I'll go through this case fairly quickly. This is the case of a patient who had a failed scaphoid non-union, ended up with a PRC 3 years later, had arthritic changes, and Bob Beckenbaugh taught me this, and this is something that we had done for a while. I haven't done it in quite a while now. But in terms of resurfacing, this is the x-ray 5 years later post-op. No pain, but you can see this pile driving into the radius. But I saw that you had put the hemi in sort of the stem in a different angle. I wonder if that would have made a difference in this case. Maybe not, but Just thinking.
I mean, I don't think so. We have not converted many PRCs to PRCs resurfaced. I mean,
Okay.
I think usually you've got that radial wear, you've lost the eburnated subchondral bone on the radius, and you're set up for this thing to subside the way this is done.
Gotcha.
I think, again, you only have one place to place it in the capitate. I mean, there's not much angle to it up or down, really. You want to center it in the capitate. I agree with Brian in an earlier statement that he made that sometimes if you have a good capitate shell, you're okay. Obviously, if you don't, all bets are off and you shouldn't do it. But if you had a capitate shell with poor bone, putting a little cement around the implant can save the day. And I have not seen it, even though we hand surgeons don't like cement. I haven't seen the problems of our total hip colleagues relative to cement loosening.
Terrific. Thanks, Lee. Thanks again. That's wonderful. So I will sort of bring us down the home stretch. We got about 20 minutes to go, and I'm going to talk about failed total wrist, which we've talked a little bit about already and to some degree. But this was that study that I quoted earlier that from Berber and colleagues looking at the encouraging data with the newer generation implants. And ultimately, that blue highlight at the bottom, higher complications with total wrist arthroplasty. Well, they followed up with a study, another meta-analysis just published a year ago, looking at how do we do with failed total wrists? What are our outcomes? And unfortunately, it's not that good. The bottom line is there's a high level of complications with these patients, reoperations. You can see the re-revision rates are quite substantial, complications 1 and 2 revision procedures. And because of that, they feel that, certainly when approaching a failed total wrist, that the likelihood of complication would be pretty high. The modes of failure that we see can involve the proximal component, can involve the distal components, and miscellaneous or various other things, whether it be collapse, whether it be dislocation, whether it be soft tissue issues, and other types of complication, which you can put in that last bucket. I'm going to share a case-based review over the next 17 minutes or so, just reviewing some cases. And I'd love for maybe occasionally tap on the faculty to give me their insights. This is a 55-year-old female with RA. She had this implant done. This is the Biax implant, which is no longer available. And Lee was talking about this earlier, that there can be problems with the lever arm just being, oh no, this was mentioned this too. The lever arm can be quite extensive, and osteolysis at the metacarpal and even frank cutout of the bone was not that unusual as they fail. And ultimately went on to have pain. And in this case, Ahmed, do you think there's not much carpus left here, buddy? What do you think it's something that you could salvage without? Are you thinking more fusion in this patient?
Well, yeah, this worries me because not much corpus left, and the metacarpal also is a problem. So I would be inclined to remove the implant and go for fusion in this case, and then certainly use the second metacarpal to put the plate in, and then pack the third metacarpal with bone graft.
That's sort of what we offered her. Lee, any thoughts or comments? Would you think
Well,
fusion?
I would do that if this was the only bad wrist. If she had a fusion, let's say on her opposite wrist, so now you're going to give her 2 fused wrists. One thing that I've done to save motion on these is to do an Achilles allograft implant for the wrist. In other words, taking out all the material, putting in a big Achilles autograft, doing a good capsular reconstruction, as Brian talked about, and trying to get that 30-30 of stable motion in the wrist. And I've been able to salvage 1 or 2, and that's about the numbers I've done it in. But I think that if you had a fused other wrist, if this is your only wrist, you're going with fusion as far as I'm concerned.
Mm-hmm. Brian?
Yeah, I wanted to comment. I actually, I don't know if I was originally described it, probably not. Lee, I agree with you, is that you have to be a little careful because this is poly that you'd have to be, putting something against here on the Biax. But when there's metal proximal units have failed and there's not much carpus, I have tried the rolled up fascia lata or Achilles and tried to make a stable wrist, and it's difficult. They tend to fall into volar, this is in rheumatoids, volar subluxation and some ulnar deviation and weakness. So I would prefer to fusion over that. The other thing is you could consider, just because I was burned by that a couple times, Lee, but if it works, it works. The other option here is like we do in other joints, elbow, shoulder, and ankle and so forth, it's written about, is you'd have to stage this. I know Hank Kurt has talked about doing it one stage with a iliac crest graft and fixating it and then putting the implant into it. To me, that's a little bit too much, but if you wanted to take this out, and I've only done it a couple times in very unusual circumstances, and bone graft this, let it heal up, and then go back and put in an implant. Again, similar to what's done for the acetabulum and the glenoid and the shoulder. So that'd be the only other option besides fusion for me.
Thanks, Brian. All good points, really wonderful pearls. Her other side was not happy, and she was adamant that she wanted to try to preserve motion. So we opted to try to graduate her to a newer generation implant. This is the Universal 2 that we used. And you can see intraoperatively that this is with the trial in place, and then over here with the final implant. She was pretty stable. We were encouraged, and we actually, the fixation distally was a challenge, and I'll show you on the next slide what ultimately was done. Screws going into the metacarpals, and some cementing was used as well. But ultimately, one nice thing about these who have these DERAs is you can make fresh cuts on the radius without being too worried about the DRUJ. And ultimately, 3 years post-op, and ultimately 6 years post-op, and now 10 years post-op, you can see this osteolysis distally. We're sort of on the clock, but and proximally, she's had some stress shielding. I think it's stress shielding. And it's, but relatively pain-free. The motion, you can see flexion extension view. She does hyperextend more so than flexion, but it's a functional arc of motion for her. And overall, I think she's quite satisfied. Now, when you look at the literature on these failed wrist salvage options, there is not a lot written about revision, frank revision for failed total wrists. This is Kurt Peterson's group, and Kurt has a tremendous experience with wrist replacements from Sweden. 16 cases with a 6.5-year follow-up, and their outcomes revealed that there was a 25% failure rate for revision. Most of these were salvaged to fusion, so the re-revision, after they failed a revision, most were salvaged to fusion. They felt, however, optimistic. They painted it in sort of an optimistic light. Revision arthroplasty is a valid motion preserving salvage for failed total wrists. However, as many as 25% will require additional surgery. Pain relief was pretty predictable, and motion, while diminished, was overall functional. We recently finally published a series of the Mayo experience in the journal, the Yellow Journal, and 76 arthroplasties in 69 patients with a 10-year follow-up. And pain relief, again, was pretty predictable. Range of motion was functional, although there was some decrease in ulnar deviation. But there was significant complication rates and reoperation rates for re-revision, as you can see from these Kaplan-Meier curves as well. And it's important that patients have that understanding when going about revision total wrist, when opposed to fusion, as you mentioned earlier, Brian, that I think we have the fusion thing more predictable in terms of a salvage when considering what to do with these patients. Another case example of a patient, I'll go through this one fairly quickly. She had this joint replacement. She was actually a fusion that was converted to a wrist replacement. And she was pretty happy with it, even at 5 years post-op, although her x-rays are sort of looking bad here. At this point, she doesn't have any pain. And Brian, you alluded to this quite nicely, that, these are often asymptomatic loosenings. Patients are happy and the patient's x-rays are not so happy. So, Brian, I think in your article with Christina, you opted to move forward with revising them before they became symptomatic. Is that right?
We did. Those were done with the original Menin wrist and probably earlier in my understanding and experience. And so I was mostly influenced by the disasters with the Biax. Many times it would just destroy the wrist once they started to go bad. Certainly there's those that performed well, but when they went bad, they could go bad quick and big time. So I was influenced by that. And I know Bill Cooney used to say, well, if it's, that's not really necessary. And so when we look at Kaplan-Meier curves, a lot of times these wrists look good clinically, but they're not doing so good radiographically. And someday we're going to decide what's a failure or not failure, report them separately. And anyway, I was influenced by that, and I went ahead and revised them maybe earlier. I think one of the things that I look for is, as you mentioned, if they're not painful. I also, and this is my current thinking, if there's a lot of swelling about the wrist, then I worry, and I don't think most of those are actually infected. And then third is if they're subluxed enough where they're going to cause tendon erosion. So if they're starting to encroach upon the carpal tunnel, and I have seen flexor tendon ruptures when these have been just basically watchful waiting or monitoring, it can lead to a problem. So those are my criteria now, where I would jump in earlier than maybe I did back then. Or sorry, differently than I did back then. Thanks,
Brian. So her clinical picture at that time was that she had no pain. This was her flexion extension arc, radial ulnar deviation, grip strength was 50% of the contralateral side. Amit Lee, are you thinking leave her be? Or are you thinking do something, act on it? What do you think?
Well, one of the things is that if you go back to the x-rays, Marco, look at the radial side. Many of the ones that I've seen, they have these cysts, and I've gone in there and just grafted them with allograft. Because as long as the radial implant is stable and it's fixed well, and many times you'll see that the radial implant right at the tip is very well fixed. So I would graft these, but this one probably has moved, because if you see the original x-rays, it was much more, centralized. So this perhaps is a little different and may require a revision.
I don't know, Marco. I always find it hard to convince a patient who doesn't have pain.
Yeah,
got to get in there. And I would tell her, listen, this is a potential Damocles sword hanging over your wrist. And instead of following you at 5 years, or when you feel you need to see me, I need to see you at pick a time, 6 months or 1 year. And if we're seeing further cystic change, even though you're not painful, you've shown me that this is a process which is progressive enough that if we're going to try to save what you have without going through a fusion or some other major revision, I think we ought to act pretty much as Amit said, and do some grafting.
Those are good lessons learned. And because as I ignored her, because I opted to do nothing, and then here she is now at 8 years post-op, and now she's symptomatic. Her exam, a couple of things that I thought were encouraging. One is her distal component looks pretty solid. That fusion really helped us out. Proximally, she's clearly subluxing, tilting further, more osteolytic, and her pain is substantial. Her motion's more diminished. Her grip strength is diminished, and I did move forward with revision in this case. Now, if we revise, Amit, what's your plan? Are you going to just cement a new proximal component in, or no?
I think in this case, I would want to go further proximally. So I would get some sort of a custom implant, which is longer stem. Okay. And I would not have any hesitancy in using grafts, because you'll see a lot of bone destruction, a lot of these synovium, which needs to be excised. And these synovium are in the pockets inside the radius trabeculae. So I'll take out everything, clean it out really good. then graft it like you did with the femoral head graft with and then pack it in, and then use a implant as you've done.
So this is a custom implant you have to get from Stryker, was the company. Stryker still owns Remotion,
yes,
is that right?
yes,
Yeah. Okay.
yes.
I know they gave away or sold off their smaller joint implants, but they kept the wrist. This is her radiographs, and she's delighted. I mean, you know, I mean, she just loves this thing. It's only been a year and a half, and the most recent, she's about 2.5 years out now, but it was a year and a half when the most recent x-rays, and these videos were taken then. So she hopefully will go on to do well for a little while longer. She knows what a fusion's like, and she just doesn't want another fusion. So, but I've told her there's a good chance that, you know, she's gonna, you know, Michelle Beckstein, when I was younger, when I went to visit him, he had a good quote about, if you're going to commit to a wrist replacement, you need to buy in, even though you're reticent, need to buy into a fusion at some point in your life. Like you had mentioned also, Matt, it's stage 1 of 2 in the end. So,
right.
Yeah. I think we have enough time for maybe 1 or 2 more quick cases. Here's another one. This is I think she's like 62 or something. No, not that much. I think she's younger, like 52. 4 years status post this wrist replacement with pretty significant loosening of the distal component. And I was younger then, and we talked to her about a fusion. She really didn't have any motion. And my temptation would be to talk to her more about possible revision in this case, given that she seems to have some good bone. But always when I talk about revision, I mention to them that fusion would be the plan B if we're having trouble. So here we opted to move forward with a fusion. She did have some considerable metallosis, which I think was largely due to the metal and metal sort of impinging on its dorsally there. And hard as heck to get that component out, but came out. This is these are the pieces after removal, and again, that bone grafting technique which we showed earlier, and this is her at 4 years post-op, and she ended up being pretty satisfied with her pain relief and her function. Our results when we published this in 2010 or 11 was not so good. Our union rates were substantially lower than we would like. They were about 55%. And we had a lot of problems. Despite that fact, we had pretty satisfactory patient outcomes overall. Now, Brian shared his experience more recently and described this pretty predictable technique of how to treat these with the femoral head allograft, which we showed a little bit of, whether it be structural or impacted, a wrist arthrodesis plate, which I think the wrist fusion locking plates are much better nowadays in terms of affording the fusion. And the fusion rates were exceptional, 95% at 4 months, which was really quite good. Complications were minimal. And this has been our experience too, now that we're using the plates more. Than that original series, we had done a lot of this time in pins, and those weren't as predictable in terms of affording the fusion. And here's a nice example of the importance of the locking plates. This woman had a pretty significant problem, 68-year-old with RA, with this wrist on the left and this on the right. And she ended up getting fused on both sides. I actually just saw her back about a week ago. And you can see this was fused a longer time ago. This was like, I think in 2015, and this was in 2007 or 2008. You can see what happens with the conventional plates, you know, that race that goes on between the bone healing and the plates failing. This thankfully went on to heal, but she has broken screw and loosening, and some screws had backed out. the locking plates really give you more solid fixation and give you more time to try to heal. And I think that's been an important advance in terms of affording fusions. Any comments or questions from anybody? Amit, Lee, Brian?
Just a quick comment. That's what I wrote in my article too, is that with the introduction of the locking plate, and again, it was the AO wrist fusion plate, that I converted that. In fact, I have one of these coming up to convert a remotion with severe osteolysis to a locking plate, and I'll use the same technique I have used. I think which is similar to yours. I do think it's important to get their wrist out to length, because if you bring the wrist shortened, they really lose their ability to make a tight fist. I mean, their fingers droop down because the wrist extensors are loose, and their power grip really drops, and it's already poor in most of these patients anyway that might have a revision. So I think it is important to use some sort of structural technique to get it back out to a reasonable length without over tightening it. I like to consider with the patient beforehand whether or not I'm going to use a straight plate like you did, or a plate within slight and extension. And even if you use a straight plate, it was just a standard wrist fusion the other day, is I'll bend the straight plate into some extension. You certainly don't want to weaken it, because that would be a bad thing. So do it in an area where you think it's not going to be under high stress, but those are the only two caveats I would say. And then the other one is to take advantage of your, if there's any tendon issues at the time, so that you can rehabilitate these patients. And then lastly, I promote that they wear a wrist brace for a long time. Most of them don't want to cast, but to release them to full activity without any protection is maybe a little bit too overzealous.
Thanks, Brian.
Marco, I would just add two quick things. One,
Sure.
I throw the kitchen sink at them, and along with the femoral head allograft and the locking plate, I use bone morphogenic protein, whether it's infused or one of the things, even though it adds to the expense, I feel I've thrown everything else at it. And lastly, I really think that the critical point that Brian made both in his lecture and just a minute ago is, whether you're fusing the wrist, putting a total wrist implant in, that you really need to make sure you balance everything. You want to balance the alignment, you want to balance the length, you want to balance your wrist extensors and flexors, because in life, balance is everything, right?
Thanks, Lee.
Yeah, I wanted to highlight in my series too, Lee, I included BMP in all of them but two. And so I can't compare with or without, but yeah, I usually put some sort of magic in there at the same time.
Thanks, Brian. Amit, I'm going to give you the last word, buddy. Oh, you're muted.
Oh, can I share my screen?
Sure, man. Go ahead.
Okay.
We're a little bit over, but we got a minute.
Yeah.
Okay.
Yeah, just if you stop sharing, Marco. Yeah.
Sorry, buddy. Okay.
Thank you. So I will say the question in my mind is why not wrist arthroplasty? I think the results of arthroplasty are getting better, as you've seen with the meta-analysis that Marco presented. The quality results are better than total or partial wrist fusions, and with minimal bone resection, you have good salvage options. The long-term results are also looking good, with over 90% 10-year survival, 9-year survival. And our patients are demanding motion, and we certainly need new modular designs. So if you see this, this is an old windmill, and you can see some of these still in Netherlands. Then the windmill changes, and now we have the modern windmills producing electricity, and now we have the vibrating windmills, which are not killing the birds. So designs change, and it gets better and better. If we stop doing this and we just say just fuse the wrist, that's going backwards. I think we have to keep going forwards and keep improving the design. Thanks very much.
Well stated, Amit. Thank you. I can't thank you all enough. I learned so much from everyone here tonight. Amit, Ali, Brian, you guys are awesome. Thank you. I've learned so much from you all over the years, and it's great to be in a situation where we can have a nice fireside sort of conversation and share our experiences. Thanks again. I hope everyone has a good evening. And next week, arthroscopy, and Lee is moderating that session. So be sure to be there.
I was just thinking, tough to improve upon this one. Thank you very much, Brian, Emmett, and Lee, and Marco, as always. Fantastic session. Thank you.
Thanks, guys. I hope you all have a great evening, and we'll see you next week. Okay, thanks.